Welcome to the Next Step in Care learning series. This video is designed to provide healthcare and social service providers with ideas and guidance on ways to work together with family caregivers.
I'm going to take the next few minutes, the next 15 minutes, to really kind of talk about having these conversations with patients and families about goals of care and options. And if anyone can't hear me, please let me know. So what I will touch upon in the next few minutes is really to give just a brief overview of the palliative care program that I presently work at New York Hospital Queens, to really discuss a framework for how to have a good discussion and conversation, and then some of the challenges in care transitions when the goals of care are comfort. And that's something that you've all been working on here in terms of transitions. So hopefully that will lead to some good discussion. So New York Hospital Queens is a 500-bed community hospital in what is the most diverse borough in New York City. That the hospital has an older inpatient population, partly because there's about 30 nursing homes who admit patients to New York Hospital Queens, and there are 9 nursing homes within the immediate Flushing area. And many of you in this room are probably aware, but the vast majority of long-term ventilator beds are also located within the borough of Queens, which really is then a trigger for this very sick, very chronically ill population of patients when they need inpatient care. This is New York Hospital Queens is one of the hospitals that they frequently come to. So there's many care issues and challenges to be addressed. So the palliative care program at New York Hospital Queens started just in 2010, and it began with a physician colleague, Dr. Pan. I joined her a few months later, and in the first year the hospital felt that, well, by the time the program gets started, probably if we saw 50 patients in the year, that would be successful. And in fact, in the first year, we saw 614 patients. So clearly there was a need, and a need that was identified by the clinical staff, and there was really a receptivity as well on behalf of patients and families. So that in 2012, our team has grown. There's now a full-time social worker for the past year and a half, and now a second physician has joined the team. We've now seen 688 patients in the past year, in 2012. And just because of the diversity of Queens, it's a diverse hospital, and it's a very ethnically and culturally diverse staff as well. And that key to all of this is we can see from the data we collect that everyone does use palliative care, that culture and ethnicity is not a barrier, as it's been identified as a barrier sometimes within hospice. But the patients we do see are pretty well distributed across ethnicities, and among the Asian population, of which Flushing is right in the heart of a large Asian population. 58% of the patients we see who are Asian are Chinese, and the next biggest group is Korean. The diagnosis, 60% of the patients we see have a non-cancer diagnosis, and the primary conditions are stroke and pulmonary problems, as you would expect given what I've said about the ventilator capacity in Queens. And that referral to palliative care, most of the patients we see are discharged from the hospital alive, and 27% of the patients seen will be referred in by hospice, inpatient hospice, home hospice, nursing home level hospice. the primary reasons why there's a referral to palliative care, primarily the major reason is really about goals of care and helping with understanding patient and family preferences and options, end-of-life care, hospice appropriateness, pain and symptom management, helping patients and families, supporting them in their decision-making process. And lastly, when the clinical team really doesn't know what to do. So, since goals of care is the primary reason why a consult is requested, I felt the best way to kind of approach our conversation is through a case illustration. So I'm going to introduce, this is Mrs. K, who's an 85-year-old Korean woman with a past history of a stroke with right-sided weakness, hypertension, and heart failure. And she had been admitted from the nursing home 4 days prior because of a change in mental status. She was found to have had a major stroke. She was lethargic and unable to speak. Prior to this admission, she had been living in the nursing home for a few years. She was dependent in her ADLs, but she could attend activities, recognize her family, and recently had participated and enjoyed a birthday celebration. She had several family members, but her eldest daughter was the primary decision maker, but made decisions with participation of her family. So palliative care was called to consult because there were issues around feeding options and potentially peg placement. So the framework for our discussion is I'm going to use what's called a good conversation. And this comes out of work from Stanford Palliative Care. And good stand for goals, options, opinions, and documentation. Okay. So when we think about goals and Mrs. K, the goals may be different depending upon who you ask. So in the case of Ms. K, the primary physician wanted a peg to be placed. The house staff really was sitting on the fence. They really didn't know what should happen in this circumstance. The case managers were wanting to know, what's the plan? When are we doing this? You know, she has bed hold. And the daughter, she wanted time. So that's the range. And knowing that is really so very important. And then, most importantly, is understanding the big picture. Because once we understand the big picture, then it becomes much clearer about the plan. If you don't have a destination, then you're kind of just meandering. And often in hospitals, what we're doing is responding to the crises of the day, or the latest problems, or sitting and talking to family about a particular procedure, or decision, or a test, without, you know, kind of the big picture plan. Okay, so that once we did talk with the daughter and ask her, what was she understanding about what was happening? It was very clear that she was very savvy. She understood how serious a situation this was. She understood that she was really hoping for the best, and she was hoping that her mother was going to wake up enough to be able to eat and swallow and take in enough food to avoid a feeding tube, and that her hope was that her mother would recover to her previous level of function. But also, she felt she needed time, and she knew she needed time because neurologically, it needs time to really show whether there'll be improvement or not. That being said, she also said that if her mother wasn't going to recover, then what was most important was her mother's dignity and that she not be in pain. So very clearly, we then went back and talked to the primary physician, the gastroenterologist who was involved, and everybody really supported the fact that she didn't want to rush into a peg. And we had to kind of figure out, you know, she was beginning to wake a bit more about speech and swallow coming back to see her, to see what the possibilities were of her oral intake. Okay, so then we get from the goals and knowing what the daughter's goals were, which was supported by the team, to what the options are. So as you think about Mrs. K, think about what the options would have been in this particular situation, okay? Then what we need to do is to really provide to the daughter and to the family information about, and to counsel them about the benefits and burdens of these particular treatments. So it's not only when we think about PEG, which was the situation here, it often comes down to PEG, no PEG, eat, don't eat, with no kind of in between. So in this situation, she woke up enough. She was able to be spoon-fed, although she was at very high risk of aspiration, and it took a very long time with her caregivers, her family caregivers sitting there feeding her. Okay, so that the discussions around risk with hand feeding was something discussed, as well as PEGs and what the benefits could be in the situation, what the options could be about short-term versus long-term, and also what the complications can be of a feeding tube. And then, when there is data, to share that data with family members, so that when it's issues such as issues like resuscitation, what do we know about when somebody's very sick, about success and failure percentages and rates for somebody when their heart stops. That's important to helping people understand what's likely to happen and what the outcome is likely to be.